I'm changing classes. Let's talk about the macrolide antibiotics. Macro means what? Big. Macrolide antibiotics. Chemically, they're very big. Why should you care? Why should you care? Because anytime a drug is chemically very big, it interacts with other drugs. That's why you care. You know the trouble with the macrolides? It's all the doggone drug interactions. Erythromycin, clarithromycin, even azithromycin is drug interactions. So when we give macrolides today, we typically give azithromycin and clarithromycin. The later generation macrolides because they have a little bit better coverage. But we have given so many prescriptions for Z-Paks in this country and created so much resistance to strep and macrolides that strep eats the macrolides for breakfast. And I'm not kidding you. So the recommendation now is to use these macrolides for atypical pathogens like mycoplasma. Because using it for strep, we now have really high rates of resistance with macrolides and strep. So it's just not the best choice if somebody has strep throat. It's so easy. 5 days, once a day, so easy. But we've used it too much. And we have so much resistance with it. Up to 40% in most communities. Well, here's our last big class. It's the quinolones, the fluoroquinolones, and these are divided into generations as well. This morning we mentioned ciprofloxacin. We said it was not a respiratory quinolone because ciprofloxacin doesn't cover any respiratory pathogens like the bugs above the belt. When you give a patient ciprofloxacin, what you're telling me you think that patient's infected with is a gram-negative organism, something in the gut, maybe in the urinary tract. It's a third choice for an atypical pneumonia. We would rather you give doxycycline or a macrolide. If you couldn't give either one of those, you could try giving Cipro for atypical pneumonia, but not a good choice at all. Would you ever use ciprofloxacin to treat strep throat? No, because strep is gram-positive, and this doesn't treat the gram-positive pathogens. Does a decent job of treating gram-negatives. Well, we only have one third-generation quinolone left. Its name is levofloxacin, and Amelie calls it the idiot's antibiotic. I call it the idiot's antibiotic because even if you're an idiot, if you give an infected patient levofloxacin, you'll get them well. So you might be sitting there having very bad thoughts. These would be very bad thoughts. Amelie, I wish you'd have just started with this one. I wouldn't have been writing down all that other stuff. Look, when I get an infected patient, I'm giving them Levaquin. It's going to get them well. If that's your thought, it's a very bad thought. Here's why. Every time you give a patient an antibiotic, every time, when they take their last dose, even when they have taken it exactly like you prescribed it, when they take their last dose, there are always bugs born after the last dose. Guess what those bugs are resistant to? The antibiotic you just gave. And when that antibiotic is Levaquin, and it's resistant to that, you got a bad bug. That's a bad bug. So look at what Levaquin kills. It kills gram-positives, gram-negatives, the atypicals, drug-resistant strep pneumo, aerobic organisms, anaerobic. Pretty much if it wiggles, Levaquin kills it. So it's a great antibiotic. But it's generic, and you know what that means? People give a lot of it. And the more often you're exposed to an antibiotic, the more likely you are to harbor resistant organisms. So we save an antibiotic like Levaquin. Listen who we give it to. For people who cannot afford treatment failure. Failure. Cannot afford treatment failure. Like who, Amelie? Like a little old lady with right lower lobe pneumonia, and if we don't cure her pneumonia, she's going to end up tubed and on a vent, and we're never going to get her off. She gets Levaquin. What about one of your oncology patients who's in a round of chemo, gets septic, they get sent to the hospital, we get cultures, they start Levaquin, and they wait for the cultures to come back. For people who cannot afford treatment failure, we give them Levaquin. So don't give it for acute bronchitis. Right? Don't give it for strep throat. So you got to be savvy about your antibiotics. And then here's the last group. It's the fourth generation quinolones. Those are drugs like Avalox and Factive. We have one that's relatively new. It's been out a little over a year. It's Baxdela. They kill the gram-positives, gram-negatives above the belt, and the atypical pathogens, which is why we use them as respiratory quinolones, right? Strep pneumo and the atypical. So those are good ones. But we don't use these to kill gram-negatives below the belt. Like, do we use Cipro for UTIs? Mm-hmm. We use Levaquin for UTIs? Mm-hmm. Do we use either of these for UTIs? No, we don't. Because they don't kill gram-negatives below the belt, all right? Now, there are 2 or 3 more antibiotics I just have to give to you. They're the only ones in their class, but you have to know them. And one of those is macrodantin, nitrofurantoin, macrobid, right? Same antibiotic. We use macrodantin to kill E. coli in the bladder. It's only used as a urinary tract pathogen, and it does a good job. This is what I would want if it was 2 days before my certification exam and I had a UTI. You know why? The resistance rate with E. coli is less than 2% with this. It's up to 40% with Bactrim. Now, which one do you want? You got it? Macrodantin, of course. Flagyl. What do you know about Flagyl? Flagyl. Oh, Flagyl. Yeah. It kills gram-positive anaerobe, like C. diff. Oh, yes, C. diff. We use Flagyl. We're now getting growing rates of resistance. And so I'll show you what else we'll use, but Flagyl, for the most part, has been used for anaerobic infections, one of those being C. diff. Clindamycin. Clinda? You give Clinda? We use Clinda to treat gram-positive infections, and usually we restrict it to MRSA, simply because clindamycin has a pretty bad side effect profile with diarrhea and colitis, and so there you go. And then here's our last one. It's vancomycin. If your background is a hospital, I'm pretty sure that when you give vancomycin, you give it IV. And I'm pretty sure you give it to your sickest patients. In primary care, we use vancomycin also, but we don't give it IV. In primary care, when we use vancomycin, we give that 125 milligram white tablet, and we give that to people who have C. diff. I'll tell you right now that vancomycin by mouth will kill C. diff way faster than vancomycin IV. And here's why it's your last antibiotic principle. If you want an antibiotic to kill bugs, the antibiotic must be able to concentrate in the place where the infection is. When you have C. diff, where's the infection? In the gut. The antibiotic you want to use to treat C. diff in the gut is an antibiotic you give by mouth because it concentrates in the gut. When you give IV Vanc, it doesn't concentrate in the gut nearly as well as an oral form. You got it? So that's why we do what we do. And so there's Vanc.